I'm very pleased to send the control of the screen over to my friend and colleague, Dr. Ken Bernard, who hopefully has recovered from a series of night shifts, to introduce our first presenter. Good morning, Ken. You look well caffeinated today.
Oh, totally. I'm ready to go. And good morning to everyone. And thank you so much for being with us on our second day. I want to jump right into it because we said this is going to be rapid fire, excellent clinical content. For our first speaker, we have Dr. Eric Wortman, who's one of my many bosses, but also as the Director of Emergency Medicine at the Chinle Comprehensive Healthcare Facility. He's Director of the Special Forces Medic Educational Program. He's figured out life by living in paradise in Hawaii and then working in one of the best clinical contexts in the world there in Chinle, which I very much enjoyed, and so is all of our group. And he's going to present a case of cryoamputation. Now, every once in a while, there's a story about a particular patient that comes across or medical intervention that comes across that just makes you say, wow. I mean, the mRNA vaccine, to think of one, I think the last one would have been stool transplants for C. diff, when I was like, what the hell is going on? But this was a particular case when when we sat down and told me about the follow-up on this particular patient, as I was involved tangentially in her care, I couldn't believe what these folks had put together, and the incredible work, thoughtfulness, innovativeness, and maybe looking back into what resources they didn't have to save this patient's life. In my view and perspective. So I'll send it over to Dr. Wortman, and thank you so much for being with us today, and take it away.
And I'm trying to start my video. The host has to let me back in. Okay. Can everybody hear me?
Loud and clear. Hear you and see you.
Great. And you can see my slides, correct?
Correct. Got them.
Great. Fantastic. So I'm Eric Wortman. As Ken said, I'm the Director of Emergency Medicine at Chinle. And I want to thank Ken for inviting me to this. It's quite a privilege and honor to speak with everybody, and hopefully what I have to say will help somebody be better at what they do. So, you know, I've been at Chinle for 17 and a half years, permanent staff for almost 14. I came to Chinle after leaving a job on Kauai, which was a fantastic job, but it wasn't working for me. And when I came here, I knew that I had found basically the vortex of emergency medicine. In touching on what was said in the first 15 minutes of this, you know, I'm also the Director of Education for Emergency Medicine here, and I have always brought medical students and residents out to work with us. I have a very long-standing commitment to emergency medicine, as I've been in practice for unbelievably almost 28 years. And also because I feel very strongly about rural emergency medicine and then working with the IHS and who we take care of. So I say that because I do have some established relationships with other residencies, but I encourage anybody who wants to have a student or a resident come spend time with us here. I would love to have them. And especially now that there's been so much focus on the Navajo Nation because of the pandemic, my concern is that the attention will be turned away once the pandemic is gone. And so we need all the support from people like you to help us continue to make medicine here on the reservation as good as it possibly can be, because the people here deserve that. So without further ado, this is a case of cryoamputation in the setting of sepsis in a resource-constrained setting. The patient was a 59-year-old, primarily Navajo-speaking female who arrived by ambulance to our emergency department with a complaint of multiple wounds to the feet. The family had found the patient slumped over in a chair, and she had been confused and weak for a few days. EMS reports that she had had foot problems for a few months. So before I go further, let me just talk about Chinle. Some of you know Chinle, like Dr. Bernard. Some of you don't. So pre-COVID, we had about 38,000 visits to our ER, which includes our fast track urgent care. The ER itself is about 9 beds. The urgent care is 6. We have 36 hours of physician coverage and 36 hours of nurse practitioner and PA coverage per day. We have a general kind of admitting staff, including general surgery, pediatrics, internal medicine, family medicine, OB, GYN, podiatry, optometry, radiology, and mental health. We have no subspecialty services. We cannot do dialysis in-house. We have a very limited blood bank, so just a limited amount of packed cells to begin with. We have FFP, but no platelets. And all of our transfers are flown out because we're so far away from everybody, hundreds of miles to a couple hundred miles basically to Flagstaff, 300 to Phoenix. And we use all those kinds of facilities when we transfer our patients. And feel free to ask questions while I'm speaking. So the patient's past history, remarkable for diabetes, hypertension. She has a history of bilateral DVTs in the past, which have been treated with thrombolytics, thrombectomy. She has an IVC filter, and she had a persistent clot in her right femoral vein. She was stage 4 chronic renal failure, COPD, CHF, atrial fibrillation by history, chronic anemia. She'd had previous transfusions. She had a chronic right heel ulcer with osteomyelitis and refused surgery in the past. I actually have taken care of this patient over the years for quite some time now. She's a very interesting woman. She basically wants us to help her up to a certain extent, but has repeatedly refused amputations. Also had a history of MSSA bacteremia.
Hey, Eric, can I break in here just real quickly?
Absolutely.
As you mentioned about the educational aspect of it, and for our younger faculty, our residents, our medical students who are listening to this, whenever you come up to, or whenever people are thinking about coming out to the res, they always ask me about, what about my acuity? Am I going to have high enough acuity when I come to these emergency departments because they think we're out here and that we see too few patients and it's not busy? But look at this particular patient, her level of comorbidity and her level of complexity when she hits the door, even as a primary care patient. And now imagine she comes to the emergency department with altered mental status and complex medical care that's gone untreated or undertreated in the era of COVID. These are the type of patients that hit our door every day. It is incredibly thought-provoking. It expands your scope. It expands your mind to try to figure out what to do for these patients. So I encourage you to not look away from the Indian Health Service. We got some pretty sick patients out here, and sometimes very difficult to take care of them, as this case will get into. And then another thing that Dr. Wortman also talked about, we went into emergency medicine because we enjoy episodic care, but really a lot of these patients are our continuity patients. We see them over and over again because of our catchment areas. So you get to know them, about their families, about their home life and where they're living. So it's kind of an interesting mix of emergency medicine, but also being able to get to know a few of our patients really, really well. Those high utilizers or high frequency folks that come in just out of necessity because of our care system. That'll be all. I'll step back. Thank you.
Right, and just to add on to that a little bit, if anybody has any doubts about the acuity here, we typically do about 120 trauma transfers a year, and this is a small ER in the middle of nowhere, and the number of medical transports, of course, is much, much greater than that. So the patient has a past history, surgical history of EGD and colonoscopy. You can see her medicine list, and most notably for us, she was on apixaban, which presents complications for us because we have a hard time dealing with anticoagulated patients. So her history and examination, she does speak some English. She prefers to speak Navajo. I put the social history in here because for our population, it's very important to know whether they have running water or electricity, whether they have family or other people that can help them. Many of our patients don't have running water. Their heat indoors will be coal or wood. They may not have transportation. And of course, this gets to what life is like here on the reservation for many of our patients. She had a temp of 98, heart rate of 117. She was normotensive. Her SATs were fine. Her respiratory rate was 15. She was somnolent. She was awake. She was very ill in appearance. She was quite pale. Her extremity exam, really remarkable for the fact that she had this chronic right leg infection, basically from thigh to foot with an open wound over the heel, full thickness necrosis. Her left leg was less swollen than the right, but she had a large open wound over the heel and over the medial foot that was draining pus, and there was air coming out of the out of the wound. She had no palpable lower extremity pulses. Data, she had a white count of 40,000. She was anemic with a hemoglobin of 6.5. Platelets were elevated at 569. Sodium was 137, CO2 13. Her renal status was worsening from previous studies, so her BUN was 65 and creatinine was 4.7. Her glucose was 126. Her CRP was 345. Her lactate was normal. Her L-Renic score, which is a laboratory risk indicator for necrotizing fasciitis, was 10. And I put that in there not because this patient was difficult to sort out clinically what was going on. Our surgeons really like to use the L-Renic score, and we use it too in cases where it's kind of borderline, whether we're looking at a necrotizing soft tissue infection. It can help us both in the moment, but also as time goes on to see if they're improving with therapy or not. Radiology, her left foot, Charcot joint at the midfoot, hindfoot with sub-Q air, vascular calcifications, and concern for necrotizing fasciitis. CT of the lower extremity basically showed the same thing, with air in her foot, but not proximal to the foot on the left. And she had bilateral lower lobe consolidations. So assessment, she had wet gangrene of the left foot. She had chronic right lower extremity infection, possible osteomyelitis. She was quite anemic, septic, altered mental status, acute kidney injury in the face of chronic renal failure, and pulmonary infiltrates. So overall, a septic patient with gangrene of the left foot, chronic diabetic foot infection of the right foot, ischemic feet, worsening renal failure, and pulmonary infiltrates, who is anticoagulated. So we're a small hospital in the middle of nowhere that has limited resources, and this is not a patient that we could operate safely on. Prior to my arrival, the patient had gotten some IV fluid, clindamycin and Zosyn, and general surgery was consulted. This consult occurred in the evening. The surgeon opined that the patient should be transferred to a higher level of care, given her complex medical problems, renal failure, anemia, and she was anticoagulated in the setting of our limited blood products, PAC cells and FFP, and lack of subspecialty services, namely infectious disease, nephrology, cardiology. So the patient, PAC cells were ordered for her. Unfortunately, the patient had anti-cal antibodies, which limited the amount of blood we could give her and how quickly we could cross-match her for the appropriate blood. We tried looking all throughout the Southwest to find her a bed. Multiple facilities were contacted. There were no ICU beds available because of the pandemic. So at this time, it's about 8 o'clock in the morning. She'd been there since about 9 o'clock, 10 o'clock the evening before. And we reapproached what we could do for this patient. Our options were we could amputate her lower extremity. This was deemed too risky due to the severity of her medical problems, the fact that she was anticoagulated, and there was limited blood supply and blood products at Shinley. We could just continue the antibiotics, the hemodynamic support, transfuse as we could, and then transfer when we can, but we had no window of when that could occur. We had talked to multiple facilities about when they thought a bed would open, and they just could not tell us. The other option was brought up by the surgeon, and this was a physiologic amputation of the left lower extremity by cryoamputation and tourniquet application. So as I mentioned before, I've been in practice for some time. I'd never seen this done. I'd never come across it. So let's talk about it a little bit. So in a paper by Pasquale et al. In the surgical interventions case reports, they discuss basically why someone would do this. So peripheral arterial disease can be complicated by tissue ischemia and gangrene. Patients in septic shock with medical comorbidities, emergency surgery may trigger cardiac complications or other complications. Patients might actually benefit from being resuscitated and medically optimized prior to surgery. And cryoamputation offers an alternative to surgery, arrests bacterial growth, achieves anesthesia, and excludes the ischemic tissue and its metabolic byproducts from circulation. It allows for better resuscitation, metabolic, and cardiac optimization prior to definitive surgery. Samuel Chen et al. In the Annals of Vascular Surgery presented 5 patients, aged 31 to 79. All patients had severe foot infections with septic shock and required vasopressor support. All 5 achieved hemodynamic stability after cryoamputation and underwent definitive amputation with a mean time of 3 days until amputation. It's important to note that once this procedure is begun, you keep the foot frozen until it's time for definitive management, which can be days. 2 of the 5 patients died. Patient 1 died on day 13 and 1 on day 14. In both cases, the patients recovered from the initial septic shock. The amputations were not deemed to be infected. One of the patients died of multi-system organ failure who also had C. diff, and the other patient, the family decided to withdraw care after impending respiratory failure demanded intubation, and they didn't want to continue down that path. Hunsaker and Schwartz reviewed 56 patients who were deemed seriously ill or hemodynamically unstable with ischemic infected extremities. The perioperative mortality rate was 14%, with death among those ultimately requiring AKAs at 25%, and this compared to a 7% mortality rate of primary amputation performed during the same time. And the higher mortality rate was felt to be a reflection of the underlying disease and physiologic factors biasing them towards worse patient outcomes. And of course, this makes sense. We're doing this on the sickest people who, of course, have the less likely to survive the process. Winburn et al. Looked at the current role of cryoamputation from a study in 1999, and they reported a case series of 320 cryoamputations. 92% were performed for sepsis. They did not see a difference in mortality from those undergoing primary amputation from those going under cryoamputation. So this kind of gets to the next step, and this is a complicated area, which is the ethical considerations. So we weren't in wartime. We were in a pandemic. There wasn't a natural disaster. There weren't things that prevented the normal medical care to be provided. It's just that we had no way to get the patient out, and we had to make the best decision we could. So we weren't trying to do something that was cavalier. We were trying to do the right thing. We had no idea whether we could or when we could transfer this patient, and the question was, is cryoamputation an acceptable treatment for limb ischemia and sepsis? And as I just showed you, there is adequate data to support this procedure's use. It provided a meaningful treatment to stop the sepsis and act as a bridge toward definitive therapy. This patient had refused amputations in the past, as I already mentioned, and I knew the patient fairly well. And we respected her autonomy. And it's a challenge, to say the least, when you think you know what the right thing to do is and the patient doesn't want to help or help in that matter. But previously we had followed her wishes, of course, as we must. And although she was generally confused, we had long discussions with her that morning, and it was clear that she understood what we were offering, and she was able to consent for the procedure. We did what we believed was best for her, so acting under the principle of beneficence, we were steering a good course in trying to do our best for this patient. And of course, in trying to do no harm, we also felt that this was something that actually was reasonable, would not do her harm, and would provide benefit to her. So let's talk about how we do it. Obviously, we obtained conformed consent, correct patient, correct site, and analgesia. In her case, she was suffering quite a bit. She was altered. She didn't require too much analgesia. Technically, tourniquets are applied above the affected area. Warming pads are placed above the affected area to prevent inadvertent freezing of non-affected tissue. The skin in the area of interest is covered with a biohazard bag or something similar to prevent the dry ice from adhering to the skin. and then the affected limb is placed in the styrofoam cooler or other container, and then the extremity is packed in dry ice.
Hey, Eric, this may have been self-evident, but very quickly on the decision of where to place tourniquets, is it at a color change? Is it at the sense of hyposthesia? Where do you guys decide to put that tourniquet? And is it like a couple centimeters above that you would put the warming pad? And then secondarily, could you talk about that, where you guys got like sourced the dry ice from? There, you know what I mean? I think that is also interesting to talk about.
So as I mentioned before, when I was giving the objective data on this patient, we had imaging that showed gas in the foot only, but not proximal to that. So we had an idea about where to put the tourniquets based on that information, that the tissue above the ankle was viable, and then of course by the appearance of the skin and where the wounds were. The other issue is where we got the dry ice. We got it at the local supermarket, and they were open. And that actually, we had another patient not too long after that probably could have benefited from the same therapy, but we couldn't find dry ice anywhere. Life on the res, right? It's a difficult situation. So in this case, the patient was taken to the intensive care unit. I accompanied the surgeon. This actually brings up a point which is very important, and I think Dr. Bernard can attest to this, which is, our facility is very collaborative with our consultants, as well as our outside consultants. But we operate in our emergency department in such a manner that we don't draw lines as to where we can help out. We help out wherever we're needed, and that goes with pretty much all of our consultants within the hospital. So I've been here long enough to have helped basically in every part of the hospital when we're asked for help. And I don't mean just during a resuscitation, but just to help somebody who maybe not as experienced with something that I've seen more of, or to help them with a procedure as necessary. The patient was consented for the physiologic amputation of the left foot by cryoamputation and tourniquets. The anesthesiologist helped us in the ICU. She only received a little bit of fentanyl. She didn't require anything deeper than that. A warming pad was placed on the left leg and torso to prevent inadvertent freezing. 2 tourniquets were applied just above the left ankle, and these were basically the same tourniquets you use to draw blood on, and we just tied them as tight as we possibly could around the ankle. The foot was placed in a biohazard bag, and then a second biohazard bag was placed over the foot, and the foot was packed in dry ice. The bag was secured so it would not leak. So we were eventually able to get the patient out later that afternoon. She was kept comfortable. Almost immediately, her heart rate improved to a sinus rhythm. Within 30 minutes, her heart rate was normal. She never had an episode of hypotension, and she was transferred later that afternoon to an outside hospital. The outside hospital course, the patient underwent a left above the knee amputation the following day. She refused amputation of the right lower extremity. She underwent dialysis while she was in the hospital. She has since refused further dialysis. The apixaban was stopped as the patient had an IVC filter and she had a GI bleed while she was in that hospital. She was transferred to a skilled nursing facility after a 28-day inpatient stay. Unfortunately, after discharge, she had an episode of hypotension and she eventually was readmitted, but she was discharged. This patient was taken care of in December, and our last contact with her on the phone was May 11th, and she was at home and doing well. The end. Questions?
Yeah, that is incredible. As I said, folks, that was going to be a wild ride, and I was only tangentially involved in cross-covering her care. And just to speak to Eric's point on a couple of things. The first thing was the amount of work that went into trying to get this patient transferred. I even think there were calls to Utah and Nevada to try to get her places. And I know we have all been dealing with this similarly, and please speak to your experience about those difficulty with transfers, especially when there was no ICU capacity for many of our patients. And we should talk together about what those solutions might be, including taking reverse transfers for maybe stabilized patients to come to our hospitals if that needs to be a patient exchange, if you will. Secondarily, Eric, you mentioned the collaboration, and you mentioned you never heard about the procedure before. The surgeon, I think Dr. Yeager, had done it before or had seen it done or been involved, but who else? I mean, obviously the patient and the primary clinical team that'd be taking care of her, but who else did you have to bring into the conversation to say, this is the course that we're going to move on? Was admin involved? Was there any risk management that was involved, or those discussions that take place? Can you walk me through who you thought you had to get in the room, the key stakeholders to move forward?
Right. With maybe I'm incorrect on my assumptions on this, but Linda, Dr. Yeager, the surgeon, and I made the decision. So Linda wanted some support. She wanted to know what I thought about it, and we talked about it. She had case experience of three in her career. Dr. Yeager trained at I think Maricopa or Good Sam in Phoenix. She also has been on the reservation forever, and she also has extensive experience in Africa. She's a phenomenal surgeon. She's extremely thoughtful and never cavalier. But we collaborated on the decision about whether to do it or not. It was still our patient in the emergency department. We try to take complete ownership of our patients in the emergency department. We use our consultants to collaborate with. We don't expect them to take care of our patients if it's not something that's appropriate. So just she and I talked about it. That was how that went down.
I love it. I mean, and I love that you're mentioning not the cavalier, but the intensive, thoughtful process, the ethical thought process of what to go forward with to try to save this patient's life, which indeed I think y'all did, and thankfully that a bed opened up within 24 hours to get her there. Can you talk a little bit about what the conversation was with the accepting facility? I imagine that surgeon, if it was a fellow or a resident or an early trained surgeon, might have had their head blown just like me. But who did you talk to there, and what was that conversation like?
Right. So we had multiple conversations with multiple facilities, and to insert a little bit of dark humor into the situation, after the procedure, I asked Dr. Yeager to call the receiving hospital again and call the trauma coordinator and say we now have a severe frostbite. Just kind of joking, but the fact was that's exactly what we now had. And they were a little bit surprised, to say the least, but Dr. Yeager explained what we had done and what to expect, and they were accepting of it. I'm sure that I would imagine the doc that accepted this patient probably had not seen this done, or maybe had only heard about it or seen it once or twice ever.
Has there been follow-up with that accepting facility? And this is always what I think would be interesting, is sort of those combined, after action event discussions or case presentations would have been extremely helpful to try to hear what their side of it was. Have you had any update from the clinical team that took care of her?
No, I actually haven't. I just followed, our notes that we received from that hospital, but that's an excellent point. An excellent point.
There was a couple of questions from our panelists. Brian Jarrett was asking the blood draw tourniquets versus using something like the combat tourniquet or another commercial tourniquet. What are typically used from the case reports that you've seen, if they even offered that information, and blood and using blood draw tourniquets? How did that decision come in?
They are the more formal type of tourniquets that you would use, right?
Got it.
And I'll tell you something, right? As you know, being resourceful, we do what we have to do, and if it works, if it's reasonable, that's fine. We don't have a styrofoam cooler, so we used bags,
Right.
And with the tourniquet, it worked. And Dr. Yeager had an experience, like I said, of 2 or 3 of these cases, and she felt what we used tourniquet-wise was appropriate.
Got it. And then Another question from Dr. Jarrett. The patient, we did just above the ankle where we saw gas or some skin changes for ischemia and the gangrene, but the patient ended up with an AKA. Do you know if that was just based on her prior vascular studies or
vascular issues more than anything? Because the tissue is viable, but she had no pulses at all down there.
Got it. Yeah. And then a fantastic question by Dr. Ayer. He was talking about this is probably not on anybody's credentialing privileges sign-offs that we sign off on all the time. So how is that added in, or when these extra procedures maybe that are somewhat out of our scope but absolutely necessary, and during these implied emergencies, how do we get around that, or how would you say that at least from a procedural and a risk management, medical, legal aspect of it, how does that work when a procedure isn't necessarily formally stated in our privileging and we're trying something out like that?
Ken, I will tell you that you are credentialed to do anything you need to do to save someone's life or limb. That's part of our policy. That is in how we credential people. So that takes care of it. Blanket cover. I lost your audio, Ken.
Oh yeah, we're trying to use the Q&A here. It looks like somebody was asking, a patient was transported with dry ice, and did they keep supplying that? Did you talk to the medical transport team to say, hey, can you get us some more dry ice, or make sure you bring it from Flag or something? How did that work?
Right, we had enough to get them to where they went, right? And the accepting team knew that they needed to have dry ice.
Sean, any of our panelists? Yeah, Sean wanted to break in with a quick question. Please do.
Yeah, Eric, thanks so much for this incredible case and amazing save by you and your team. And I just want to kind of express real appreciation for how you framed it and the seriousness with which you and your team approached arriving at this life-saving decision for this patient. And I think that there's a lot of folks on the call who have experience working in these settings, and some who don't. And I think the way you frame this case, I think demystifies a false notion that when you're in these remote settings, there's just kind of some crazy stuff that happens. And I think there's a little bit of a reputation that just stuff happens in the settings that we work that are unorthodox, and it's maybe sometimes not always clear how serious those decisions are and how thoughtful they must be, and how exhausted every other possible resource has to be to get there. So I really just wanted to thank you for the framing of this conversation, because for everyone on the call who works in a place where it can be hard to get patients dispoed from, and you encounter something that is going to put you into an unorthodox place, you're working extremely hard to make sure you're making the right decision. Clearly, that's what the team did in this case, and just wanted to make that quick comment.
Thank you very much. I appreciate that. We talked a little bit, and Ken talked a little bit about difficulty in transporting patients, and obviously this is one of those cases. I just want to comment about two types of patients in different settings, and how it's so important that we maintain our thoughtfulness and autonomy and responsibility as physicians, right? So I had somebody several years ago who had an acute MI, and we couldn't get her out. It was an ST elevation MI, and so we gave thrombolytics. She immediately started to bleed out of her mouth. She was in the ER for 17 hours, managed by the ER physicians, because we could not get her out anywhere. So this is a very serious decision to make. These are the resources we have. We have to do the best we can, and there's some shared decision-making when that occurs. So the patient understood we couldn't get her out. We're going to give her this medication that has serious implications if she has a complication, and she survived and did well. But many people, if they're in more resource-rich hospitals, don't have to face those kinds of decisions necessarily. Also say that about a year and a half ago, I was teaching in Haiti and working at Mirabile in the emergency department. And I'm going to bring this case up just to think about the ethics of what we do and what we are charged to do as physicians. So a boy hit by a motorcycle, fell off a motorcycle, with a probably critical brain injury, exposed brain matter, open skull fracture, came into the ER and he's seizing. No neurosurgeon available in the country. So what do we do? And we do it. There's nobody else to make these decisions for us, right? We care for the patient the best we can. Perhaps one of the most important things that we do as physicians is to relieve suffering. With limited data, no CT scan, no one there to tell me what to do, no one there to tell the residents what to do except me with them. And so my point is, you know, as physicians, we have great responsibility, great latitude in what we can do as long as we use those powers responsibly. So for this young man, we did our best to stop his seizures and make him comfortable until he passed. And I bring that up only because the ethics of what we do don't change no matter where we are. What we can do changes where we are, right? So that's what I have to say about that. So, and again, I thank everybody for allowing me to speak, particularly to Ken and to Ken Bernard. Thank you, Ken.
Of course. And thank you so much, Eric, for your experience and leadership at Chinle and across the board with the Indian Health Service. We certainly do appreciate it. I don't think I can close out the presentation any better unless folks have other questions. And again, to say and to reiterate to some of our trainees who might be on the call and some of our younger faculty, or heck, even our mid and late career physicians that want to come out and experience the practice of medicine on the res, as it is incredibly rewarding and at times some of the most challenging type of medicine that you'll face. So again, to always keep your mind open to coming out here and help. We'd love to have you.